Hello.
Hello, good evening.
Hi. Good evening, Olive. How are you?
I'm fine.
Wonderful.
Okay,
Excellent.
it's
Shall I
good to
just
have you
try
on board.
sharing? Thank you. Thank you for the
Uh,
opportunity, and I'm looking forward to interacting with all of you.
okay. The PowerPoint is still downloading. It's quite a big file.
Yeah,
But we will move on. When
that's
it downloads, I can share it
no,
with others.
I can just oh, in that case, can you hold off on that, please? I thought it was just as a backup for this. So there is a lot of material on some of it which I may need to just be a little careful before sharing. So if it's something you would like to share with the rest of the group, just let me know and I'll probably send you another version if that's all right.
Okay. Probably after the lecture, you can send us a version we can share with people.
Yeah, I can do that. Uh,
Okay.
could you tell me if my slides are visible as of now?
Yes, very visible.
All right, perfect.
Very visible.
Do you want me to keep this on or shall I just come back to this at a later stage?
No, I didn't get you.
Do you want me to stay on this for now or do you want me to come back to it later when it's time to start?
You come back when it's time to start.
All right, perfect. Okay, I can do
All
that.
right. Thank you. Let's give a few minutes for it to be 5 o'clock.
Sure.
Then we can start.
Yep,
Thank you.
no problem.
Welcome. Good to see you.
Thank you. Thanks. You too, Olive. You too,
Bye.
Olive. Yeah.
Okay. Okay. Good evening, everybody. I think we can start. We can start because our presenter is already online. we don't want to waste time because this is 9:30 in India. It will be fair enough that we start up this meeting and end so that everybody can rest. Can you hear me?
Yes.
Okay. Okay. So good evening, everybody. I want to welcome us to today's meeting. We apologize for the peculiarity of difference in time zone that has made us to start this meeting earlier than we usually do. I want to thank Dr. Babu for accepting to come on board and discuss this crucial topic for us. I'm so grateful, sir. It didn't take so much for you to accept this responsibility. So I'm really grateful and I do not take it for granted. So in our midst today, by way of introduction, is Dr. Ibrahim Samuel Babu. He is the Vice Chairman of International Council of Cardiovascular Prevention and Rehabilitation. His CV is intimidating, but it's something everybody aspires to get to. So we really appreciate that you have done so much for yourself and for your community. He's a cardiopulmonary physiotherapist. He's also an associate professor of the Department of Physiotherapy, Manipal College of Health Profession, Manipal Academy of Higher Education, Karnataka, India. He's an honorary research fellow, School of Health and Wellbeing, College of Medical, Veterinary and Life Science, University of Glasgow, UK. Dr. Babu is an honorary fellow, Department of Cardiology, Austin Health, Melbourne, Victoria, Australia. He also belongs to the WHO Development Group for Package of Intervention for Rehabilitation in Ischemic Heart Disease. He's also an associate editor of the Heart Failure Journal of India. His CV goes on and on. So we are very happy to have you in our midst, sir. You know, they said, and when you want to grow, you should stand on the shoulders of giants. So this evening, we have come to learn from you so that our patient care could be more impactful. Thank you so much for being with us. On this note, I declare this presentation open. Dr. Babu, you have the floor now. Thank you.
Thank you, Olive. Thank you for your wonderful and kind invitation. And on behalf of ICCPR, I'm very happy to do this presentation to all of you today. Uh, I stand on the shoulders of those gone before me, and from people I have learned. So I think it's a community where we learn from one another, and I hope this time is one that we get to learn a lot from one another. Okay. Olive, can you just tell me if my screen is visible?
Yeah, it is visible, sir.
Olive, is this all right? Can I go ahead?
Yes, please.
Yes, please.
All right. Thank you. Thank you so much. Right. So, good evening to all those from Nigeria and greetings from the ICCPR. I know it's a little early and I apologize for having shifted the time a couple of hours ahead than what you're generally used to. But thank you for accommodating. And I'm here to talk a little bit about cardiac rehab. Um, I have tailored the talk to focus a lot on some of the evidence that we do have, but I'm also aware of the situation and the low resource setting. And much of India and many places that I have worked in the past as well have been quite low resource setting. So I do have a strong passion towards ensuring that cardiac rehab is deliverable even in the lowest of settings. Just some disclosures and funding that I do have, which I thought would be important for you to know. Uh, Starting off with the basic definition of what is cardiac rehab. This is just one of the many definitions that we are aware of, and it is a multidisciplinary secondary prevention modality. And the goal of it is to reduce mortality and morbidity among patients with heart disease. And it, of course, we focus a lot on improving symptoms, functional capacity, and overall health related quality of life. The core components of cardiac rehab were updated just end of last year, and they are an update from the 2007 CVPR core components. A lot of it remains the same, but with a few tweaks. So it starts off with patient assessment and looking at various components of assessment. It also talks about how this could be delivered, which may be at a center, it could be virtual, or it could be a remote program. And as we talk a little bit more, I'm going to say how a lot of these can be done even in a low resource setting. And in the discussion time, I'm very happy to hear from all of you how you think it can be taken forward. The subsequent components that should be a part of rehab are aerobic exercise training, strength training, physical activity counseling, psychosocial management, cardiovascular disease and risk factor management, nutritional counseling, weight management, and body composition. And all of these are tailored to the individual and to the participant. So it is an individualized plan that has to be formed and developed. And at the end of it, it doesn't just end with delivering a program, but also talks about how we need to go about thinking about the quality of the program that we deliver and strategies to look at improving the quality of services that we can offer our patients. So these are the core components on which cardiac rehab is formed. And I know many of us as PTs focus a lot on the exercise and the physical activity part. The cardiologists and the physicians would focus a lot on the risk factor management. Sometimes we are privileged to work with clinical psychologists, but not always. We again may not have access to dietitians who are there to support our patients, but nevertheless, I think a lot of it is where, when we talk about later how we can actually develop, build a cardiac rehab program, we're going to see how various roles come together. Evidence is strong to support exercise-based cardiac rehab. This,
Excuse me, Dr.
pardon?
Babu, sorry to interrupt. Your friends are
Yes.
not moving. Is it deliberate? Your
Pardon,
friends
I'm
are
not
not
able to hear you
moving.
clearly.
So it's still there is no moving. We are still on the first slide. The slides are not
Oh,
changing. I expect that. Yes.
okay, just a minute.
Yes.
Sorry
Yes.
about
Thank
that.
you. Yeah.
What about now? Is it moving ahead now?
Yes, sir, it's moving ahead now.
All right,
Yes,
great.
it's okay.
Okay, so sorry to have gone on a bit without that information, but maybe what I'll just do is I'll just touch a little bit on the core components because I think this is something that's important. Oh, for some reason I can see my face down there now. Okay, so the core components of cardiac rehab, like we talked about, this is just a slide that accompanies everything that I said, but it's just in case you want to get a feel or a vision of what it is, the core components. And they're available, freely accessible, open access from Circulation and the Journal of Cardiopulmonary Rehabilitation and Prevention. The evidence is strong to support exercise-based cardiac rehabilitation. This is a recent update of the Cochrane review that was done by Rod Taylor's team at the University of Glasgow. And they did only go on to support and generate more evidence to support the benefits of exercise training in terms of improved health-related quality of life, cost effectiveness, which are accompanied by a reduction in cardiovascular mortality, myocardial infarction, and hospitalization. The recent European Society of Cardiology guidelines on the management of cardiac disease has brought out strong evidence-based recommendations on the need for exercise. So if you look at the boxes on your left-hand side, you see that a multidisciplinary exercise program improves cardiovascular risk profile and reduces cardiovascular mortality. So that's a class 1, level A recommendation. You also need to introduce healthy lifestyle, and these need to be done through a multidisciplinary approach. Again, a class 1, level A recommendation. Aerobic activity for at least 150 to 300 minutes per week of moderate intensity, or 75 to 150 minutes per week of vigorous intensity, a class 1, level B recommendation. Home-based rehab and mobile health interventions do improve healthy behaviors. The evidence is not, the recommendations are not too strong at this moment, but nevertheless, it's only a matter of time before we are able to generate high-quality evidence in this place as well. The American College of Cardiology brought out these guidelines which support on the management of chronic coronary syndromes, and these were the recommendations for cardiac rehab. Acute coronary syndromes or an ACI are probably the first contact that we have with our patients when they come into the hospital. And if they are managed, it doesn't matter how they are managed. They may be managed just medically or just managed conservatively, or with a stent or with surgery. But even if they just managed conservatively, the level of recommendation and the class of recommendation is that you have a class 1A recommendation for a referral to cardiac rehab, because there are benefits seen in terms of readmissions, death, functional status, and quality of life. And again, it is reasonable to alternate with a home-based program. Again, level of evidence a little low at this point, but nevertheless has scope to go up. How important is cardiac rehab in the overall care of acute coronary syndromes? And this was published again earlier this year, which looked at quality indicators for management and care of acute coronary syndromes. And if you notice that cardiac rehab is one of the quality indicators for acute coronary care. So if defined as providing quality care in acute coronary syndrome, a cardiac rehab has to be a component of it. Unfortunately, cardiac rehab is available in about half of the world, but greatly underutilized. And this is the next few slides going to talk about data that we did find from the ICCPR global survey done around 2016 and 17. And I thank Sherry and Gabriella and ICCPR for these slides. So when we looked at it, the availability of cardiac rehab by region, we find that it's not very high, and the number of countries or regions that have more than one cardiac rehab center. When we looked at the density of cardiac rehab, we see that the number of available for eligible patients is not very high across the globe, which means that you need so much more centers if we have to cater to the burden of ischemic heart disease. It's almost 1.6 million centers. So it's almost 16 million centers, sorry. And that's not something that is easily achieved. This is across the world. And this was in 2016 and 17. So with the increasing burden of heart disease, we only expect these numbers to be much higher. And we need more cardiac rehab centers coming up to cater to them. What about in low middle income countries? in lower middle income countries, cardiac rehab is available in only about 40% of all the countries. And in Southeast Asia, specifically, if we were to look at it, it's available only in about half of them. So if we look at the greatest unmet needs by country, India leads the way. For the burden of ischemic heart disease that's needed, we need at least under 3.3 million more centers. But across all low middle income countries, we find that there's a need for under at least 14 million centers more to cater to the burden of ischemic heart disease. So the big question, why is cardiac rehab so underutilized, and what are the factors that are probably contributing to this? Again, a wonderful review done by Rod Taylor and colleagues a couple of years back, which looked at barriers to cardiac rehab across the society or health system level, at a clinician level, program level, and at a patient level. Now, many of these are barriers that we've all come across, we all experience day to day. So the first and foremost being the absence of a program that in itself, and lack of universal healthcare plans to incorporate cardiac rehab. This is a challenge across most low middle income countries. Poor awareness of cardiac rehab and no to low referral rates, lack of primary and acute healthcare providers to even provide basic cardiovascular care, let alone deliver cardiac rehab, lack of trained staff, funding, and of course, awareness even from the patient side. And when it comes to the patients, I think there's a lot more, especially when they're paying out of pocket, when distances are far from the center. So too many barriers, but there are still solutions that could work. But nevertheless, the barriers are a major challenge. A couple of nice infographics, which we talked about how we looked at cardiac rehab services and barriers and pathways that affect accessibility. Again, similar things at the patient level, at the provider level, and at the health system level. And overall, if we looked at everything all together, we find that you could look at all these patient, provider, and healthcare systems, and also policy deficiencies, which are contributing to a great amount of challenges to cardiac rehab. Reimbursement plays a vital role. If cardiac rehab was reimbursed, chances are that you would get more participation, but again, unfortunately, only a very small proportion is reimbursed. So what is the situation? And a lot of this information was from around the world. But if we were to look at it from a low middle income country perspective, what is it, and is there a difference? So we did interview healthcare professionals from different settings in India, and we did also come across some other papers that we looked at from an LMIC perspective. And what we do see is that, again, you have the similar structures about society, clinicians, programs, and patients, where we are seeing significant differences and challenges to participation in rehab. I'm just going to not go through each of these in great detail, but I'm sure many of us relate to a lot of these challenges that are there. When we looked at it specifically with challenges and inadequacies, we did find among the inadequacies that there is a perceived lack of competency to deliver cardiac rehab, and along with ineffective utilization of existing manpower, underutilization of tele-rehab, limited centers, trained professionals, and task sharing. The lack of infrastructure, referrals, challenges, limited potential for revenue, cost, and time, again, are challenges that echo all the challenges that we've seen across the world. So not too different when we compare what's happening in low middle income countries. Now, this was a bit of interesting information I did find specific to Nigeria. And this was a paper done a few years back. And some of the two main barriers that they did highlight were around professional concerns and management and policy issues. So in terms of inadequate skills, awareness on the role of healthcare professionals, and of course the need for interprofessional collaboration. And I thought this paper was very important because it helped me use this as a foundation to gauge or to prepare the rest of the talk. And it did help quite well. In terms of non-existence of cardiac rehab units, we're going to talk a little bit how we can actually go about setting up a low-cost unit as well as a top-end model. And of course, challenges around having an enabling environment and funding. Those are challenges that are, again, common almost everywhere. A little context that I took to understand the healthcare system in Nigeria was based on a paper that was published in Circulation a few years back on the threats and challenges to implementation of cardiovascular disease management and control. And this particular section struck me because I do understand the situation. And a lot of these are, again, quite common across low middle income countries, and it's a challenge very specific to low middle income countries, especially with respect to inefficient and weak health systems with limited funding. Uh, there is the out of stock syndrome, which is quite common in many places as well, and availability of national data. And again, that feeds into the fact that it's sometimes difficult to have universal health coverage and many other factors. And a lack of a system to measure the quality of care. And that I think these all intertwine very well and create immense challenges, but there is potential for us to still work and come up with solutions to improve on these. So now we'll spend a little time talking about what can be done. And I think during our discussion, I'd love to hear from all of you as to what other ideas, because you work in those settings, and it'll be very interesting to learn from you on how things can be done differently. So obviously, the common ones would be, let's say, let's improve awareness, let's get trained better, let's learn to manage our load, and let's talk about holistic care. But how do we go about these? So if we talk about improving awareness, well, simple things. This talk, for example, is a perfect example of looking to improve awareness. You can do it through social media these days. Newsprint should never be underestimated. I think there is a lot of potential in magazines, newsprints, posters, use of television, radio, and in the current context of social media, I think you can even have blogs running, you can have YouTube channels running, you can have Insta channels running, and you can do a lot with it. This was a recent patient session that was done in another part of India, in the south of Kerala, and we did do a patient education session conducted in the local language for them. So this was something that was very well received. In terms of training, as the vice chair of ICCPR, I would talk a little bit about the Cardiovascular Rehab Foundation certification even later on, but there are options available for training. When we talk about task sharing, we are trying to see how we can make use of the existing manpower that we have. Can we utilize the healthcare team to help us in delivering cardiac rehab? Can some other members be involved? Can we involve nurses? Can we have involve other healthcare providers? Can we include social workers? Can we include non-physician healthcare workers? Anyone who's there in the healthcare team to help us deliver cardiac rehab. It may be counseling, it may be nutrition advice, it may be just ensuring that they're sticking to their healthy living module or their advice. Are they eating right? Are they exercising? Are they taking their medications on time? It may be just a simple thing, but it doesn't always fall on one person. You can involve more people, and can we do that? When we talk about managing holistic care, can we talk about task shifting? So if there's someone better qualified, can we have them take it over? Can they do that for us? And can we then focus on only what is essentially ours to do? Can we think about affordable clinics? Can we piggyback on existing health programs? So a lot of times, it is sometimes good to piggyback on existing infectious diseases preventive programs. It may be HIV programs, it may be hypertension programs, but can we piggyback on those existing programs that are there and then talk about reaching out to those with heart disease and thinking about implementing cardiac rehab? And can we use the home-based program to minimize participants from coming into the centers, often reducing their expenses? And can we look at how we can deliver home-based rehab? All this, again, is one solution, but unless you advocate for cardiac rehab, unfortunately, we don't reach very far. And this was a paper that, as part of ICCPR, was done almost 10 years back in 2016, and where we talked about how we look at strategies to look at advocacy for outpatient cardiac rehab. And it again starts with sharing the cause. So you make people aware about it, you talk about it, you give speeches, you contact your local legislators and political leaders, you influence them to be able to be an advocate for cardiac rehab. You create patient groups, and the picture that I showed you of was a session that I did a few days back for Heart Failure Awareness Day, and that was for patient groups. And that is, again, one way to do it. And patient support groups are extremely powerful and very strong advocates for your rehab program. It is extremely vital to start thinking about whether you can start bringing groups together. And remember, if your advocacy program needs to be strong, you need to have a just cause, relevant literature. It has to be evidence-based. You need support. As a community, you need to come together and show a unified front, have a very clear plan, but most important is to be persistent. You cannot stop advocacy initiatives no matter what. It takes time. Facilitate referrals. Well, different ways to do it. So at our center, for example, we have blanket referrals. We don't necessarily wait for a referral from the cardiologist. We are free to choose our patients. All are by default can be taken up, but again, based on our manpower availability and capacity, we sometimes do need to modify that. Automated referrals. So if you have electronic records, the referrals are automatically sent from, if the patient is in the cardiology ward, meets a certain criteria, they're automatically referred to cardiac rehab. You could also have dedicated staff working specifically there, but we all know that that's not probably the most feasible option. Many of us work in multiple areas at the same time, and it is difficult to have one person to be dedicated just to one area who's going to ensure that we can see all patients who are there. There is a lovely program on promoting patient participation in cardiac rehab, which is an online training module for healthcare providers. This is available on the ICCPR website as well, and was done by Professor Sherry Grace and some of her colleagues. This is a nice module to just give you an idea as to how you can go about promoting patient participation in cardiac rehab. It's freely available and online, and I encourage you to go through this. The recovery phase during an acute event is a very teachable moment, and this is the opportunity that you need to take to provide a good amount of education to get your patient ready for cardiac rehab. And this was again published earlier this year when we looked at to look at what are the components of education. So it's very important to talk about why they probably got admitted, what can they do to get better in terms of healthy lifestyle, about their medications, how do they take it, how do they manage symptoms, how do they get back to their regular activity, are there any psychosocial considerations? And in our experience over the last few years, we've been focusing quite a bit on the fear of movement or kinesiophobia, which we earlier thought was very specific to only those with musculoskeletal injuries, but we see a lot of it even in our cardiac patients as well, especially those undergoing cardiac surgeries. There is a significant amount of fear that stays on, and there have to be strategies about dealing with it. And when we did interview cardiac rehab professionals from around the world, what we did find was that many of them just said, well, it's just part of the process there. It's okay. It doesn't require anything. But we do know that from a functional perspective, it does have a significant role. So with these in mind, ICCPR also in a few years back came up with uh, a few recommendations that could be used to promote uptake of facilitate entry into cardiac rehab. And these were to use any healthcare provider on the floor. So it may be a nurse, it may be a PT, any healthcare provider to promote cardiac rehab. And if this is done face to face with the patient, that is the best. And that is one strategy that could be used to promote cardiac rehab uptake. And also for those who live far away, that we need to be thinking about how cardiac rehab could be delivered remotely. And those are ways to again look at improving home-based rehab or with some digital monitoring devices. So if we think about how we can get patients, and we also need to think how we're going to deliver it. And uh, we have this was again in one of the textbook chapters in a cardiology textbook published a few years back, where we looked to see how you could actually go about setting up a low-cost cardiac rehab lab or clinic. Now, testing, a simplest thing, we do functional tests. As per your guidelines, you would love to have a treadmill or a cycloergometer where you can measure peak oxygen consumption or peak VO2. But we also know that we have a number of functional tests, such as a 6-minute walk test, which we could use just as effectively. We can even use the incremental shuttle walk. And none of these require anything fancy. You just need some space. A heart rate monitor or a pulse oximeter is something that all of us have fairly good access to. But even if you didn't have that, you can still monitor pulse rate and blood pressure, even if you didn't have anything else. Body composition, you can always calculate BMI. A weighing scale is always available. An inch tape is always available for waist circumference. Physical activity levels can easily be calculated from questionnaires. We use the simple 2-question method. So we ask them how many days in the week have you been active, and each day how long have you been active. You multiply that two together and you get the number of minutes per week that they have been active. So that's just a very simple way to build in these questions, and you can just do it quite well. Again, in terms of strength training, you could do it with best equipment that you have. But even if you didn't have all of that, simple things like using water bottles, plastic bags filled with sand, your own version of sandbags, so to say, using body weight supported exercises, your options are endless again. In terms of staffing, yes, we may not have the entire cardiac rehab team with us all the time. They're quite hard to come by. But if you are the only PT who's there, then that's where you need to share some of the responsibilities with what others do. And you may need to take on. But if you do have someone else who's able to help you, think about sharing that load with them or shifting some of the responsibilities to them as per their ability and capabilities. Delivery models at high-end clinics all emphasize a lot on supervised programs, but these days with telemetric monitoring, but these days they also do focus a lot on home-based, but with high-end technology. Now, in our experience here at Nepal, we've been doing a lot of home-based programs primarily. There was a time we did have a very good supervised program, but after COVID, we've been primarily focused a lot more on the home-based programs. Our research has been in that area as well. And what we do see is that a lot of home-based programs can be run quite well with just telephone calls and monitoring their symptoms. You can maintain all your records quite well with paper. You just need to have a way to organize them and file them. And yes, you may not have the luxury of administrative staff. And again, that's where sometimes we need to do more than above and beyond our regular clinical work. And there's always some administrative
Sorry to interrupt you, sir, but we can't hear you actually. Your voice is. Yeah, now we can hear you.
All right. Thank you. Where did you lose me? Was
Previous
it at this
slide.
slide?
No, the
Previous
previous
slide.
slide.
Okay.
Yes.
Over here. Okay.
Yes,
Yes.
So,
previous,
all
yeah,
right.
thank you.
Okay. Um, so I think somehow my mic has gotten muted. Sorry about that. Um, yeah. So the idea of this was primarily just to say that low cost cardiac rehab clinics can be set up quite effectively with little to no cost, little to no space. So even if you had a small room, these can easily be done without too much of a concern. You could quite easily run your program, and if even if it is supervised, all you need is a little space. If you have a rating of perceived exertion printed out and kept, that's your intensity targets, and that works really well. And we've been using that a lot with a lot of our patients as well. The WHO package of rehab interventions for cardiopulmonary conditions was brought out by the WHO. There are 9 other conditions that are also available, so please look through them. They are freely available on the WHO website to be downloaded. You may find other conditions, musculoskeletal, neurological conditions as well, which may be of benefit to you in your practice. This was created with the idea to look at how is it that various components could be addressed at a very basic level. So, what is the bare minimum that we need to think about when we evaluate a person with ischemic heart disease? So, it aligns quite well with a lot of the evidence and the core components that are there, with some slight variations. But if you notice, we again talk about cognitive function, which includes a lot of psychosocial factors. So we talk about fear avoidance behaviors, kinesiophobia. We talk about cardiovascular functions in terms of heart function and blood pressure functions, muscle function and balance, exercise capacity, vocational assessments, lifestyle risk factors, self management, and also career and family needs. So, a carer and family needs, sorry about that. And these are as assessments that we could easily do. And these are just the bare minimum, because when we think about rehab, remember, it has to be beyond just exercise and physical activity, but needs to be a more holistic approach to the patient. Now, if you were to use technology, uh, we immediately think that, oh, well, technology is not going to work because, well, we don't have enough coverage of internet. Our internet is bad. Everyone doesn't have a smartphone. That is true, which is why when we proposed the technology driven model, what we did think about was, can we use any form of technology? It doesn't have to be just a video call or a messaging service. It can be telephone calls. It can range from a simple telephone call on an ordinary mobile phone to, of course, someone who has everything, and you can obviously look at doing much, much more. The American Heart Association brought out this advisory statement a couple of years back, which talked about how you could use digital technologies to deliver cardiac rehab, uh, either in a synchronous manner, which is where you would monitor the patient directly, but virtually, or asynchronous, where a person would exercise and their devices would upload all the necessary information and data, which would then be reviewed by a clinician who will then be able to tell them what to do. So these were 2 models that came across over a period of time. But in low resource settings, we know that that's not always going to be the case. And home based exercise training is probably a good option to consider, especially in LMICs. And based on the technology model, we could just range it from a simple telephone call. If the person was comfortable with a message, you could send them a message. If they wanted to do a WhatsApp video call, they could easily do that. If they wanted to do it on a platform, they can do it that. You want to send them an email, you can do it. The options are endless depending on what the person has access to. And through that, you can easily go ahead and do your assessment, deliver the intervention, monitor your participants, and also conduct the necessary follow-ups that are needed, all without having the person actually come into your own center. So this helps you reach out to a much larger number of people. Now, when it comes to exercise training and prescriptions, we are all familiar with probably the guidelines that are there. And so I'm not going to spend too much time on this. And again, here, I tailored the talk towards those of you working in extremely resource constrained settings. So where you may not have any form of equipment whatsoever, no formal rehab programs, but as PTs, what can you do in these settings? So if you have patients with acute myocardial infarctions coming to you, uh, the simplest form is if they have received medical therapy, start with just a simple form of exercise, starting from moving them in bed initially, progress to getting them to sit maybe edge of bed initially for a little while, progress to sitting them a little bit more, get them to do more activity, and finally get them to walk within the room, move outside, and get them to do standing and stair climbing activities. So remember, through all of this, you are going to be monitoring your patients for their vital signs really closely to ensure that they are safe throughout the entire process. So this is a very simple thing that you can do, and in its simplest form, this is what you could look at. This became part of the management algorithms by the Cardiology Society of India for management of ST elevation MI. And what we see here is that there is a referral. Sorry, there is someone's mic on. If you could please mute your mics, please. Okay. Right. So there are different levels that you can go through. So if patients are referred to cardiac rehab, there are different levels through which a person can progress. And if you notice, we have divided it based on frequency, intensity, type, and time. And in the early stages of an acute coronary syndrome, you start at a very low level with very simple exercises, just some active exercises to the lower limbs, some breathing exercises, and you ensure that the heart rate does not go beyond 20 from the baseline. You may be able to deliver these sessions 1 to 2 times a day. As the patient is comfortable with that, you can obviously progress the lower limb exercise. You can get them to start to sit and stand and walk around the bed. And then again, as they can do that, they are able to do much more. And you can think about getting them to do stair climbing as well and increase the duration of exercise. But remember, you are monitoring heart rate, blood pressure, and symptoms of angina and dyspnea. So if you notice from all of these, you do not need a lot of equipment to run all your initial early cardiac rehab programs. Um, may I please request participants to put their mics on mute, please? Okay. Um, so as at discharge evaluation, you could look at assessment of the core components of cardiac rehab with evaluations of functional capacity, which can be done again with a 6-minute walk test. Now, again, all of these can quite easily be done with minimal to no equipment at all. All of these are very simple done. And of course, at the end, you are looking at risk stratification, which may be a little more complex at times because you do require ejection fraction and other things. But nevertheless, even if you didn't have any of these, you could still look at estimating the risk of patients and most importantly, ensuring that they get a home-based program or an institution-based cardiac rehab program after that. Now, this all seemed well and good, and we thought, well, this is good. So let's look and see how feasible it was to actually implement this. And when we looked at this on 50 patients, we did find that it was actually quite possible and feasible to implement it. But we did find that there was a modification needed because the duration of stay was quite short for most of our patients. And we did need to split the third level, which was sitting, standing, walking, and stair climbing, into two different sub phases there. Just because many times our patients would only achieve a good amount of walking, uh, but not stair climbing because they would be getting discharged that day. So we wouldn't be able to do stair climbing before discharge. But overall, this is one example to show you again, another example built off the ACS uh, group of individuals on how you can do things in a very simple manner without too much equipment at all. Heart failure is another challenging group, and we did look at to see how it can be used in the acute, subacute phases, especially during an acute admission to hospital. So they may be in your general medical ICUs or in a cardiology ICU, especially when they come with acute pulmonary edema. So the initial parts, you may need to look at some amount of respiratory care, and you could aim to start some early mobilization. But definitely, you need to start thinking about if it is from a cardiac cause for the heart failure, you need to start thinking about how you can get them to participate in a structured phase two cardiac rehab program. And once they are in the wards or they're stable enough to be shifted, and doctors have transitioned from intravenous to oral diuretics, that is the time where you could start looking at mobilizing them even more, bringing them to the edge of bed, standing, promoting their activities much more, and of course, getting them ready for a home-based program. I'm happy to share that this same model was used. We used the same level 1 to 4 model. But again, our only monitor was dyspnea, heart rate, blood pressure, and angina. So we've limited it to very specific symptoms and vitals, which again do not need any extra cost. Now, this was developed and structured in a much, much better way by one of our PhD students, Ms. Akhila Satyamurthy. And she has done some excellent work in getting this algorithm together, which we developed through a global consensus. We now have a structured physician referral criteria. So a physician uses a checklist and says, based on a lot of signs and conditions, whether the patient is ready for a referral to rehab. As a PT, we perform a detailed evaluation, which is again guided by a checklist. And based on our assessment, we decide whether the patient is ready for mobilization or not. If the patient is ready, we progress through the green boxes here from in bed to edge of bed to out of bed, standing, and walking. And all of these levels have aerobic resisted exercises with or without a component of balance training within them. And we have created a number of exercises within each of them that a therapist can choose from. Um, the safety criteria to ensure that things are done in a very safe manner are done with this algorithm, where we have ensured that patients are again monitored frequently and effectively and efficiently. Again, focusing primarily on the vital signs and symptoms. So again, you do not need a lot of equipment, but you need to be quite attentive to your patient to ensure that they are moving forward quite well. And we found that it is actually quite safe, and we are able to actually get patients to exercise at much higher intensities than with our regular mobilization programs. So that is something which is needed, and which could be worked out and implemented quite easily in any setting. There is a structured education program that accompanies this, so it does require a little bit of training, but nevertheless, it is quite easily done. Uh, so if we looked at how we need to take a lot of our rehab programs forward, we need to think about how it's going to reach people, how is it going to be adopted, how is it going to be implemented, and how is it going to be maintained. A lot of this is related to the heart failure algorithm that I just showed you, but you can apply a lot of these to any form of rehab. So if we were to look at it from a general rehab perspective, you can think about it and see what are the roadblocks and what are the solutions that you can come up with. If your patient has been successful in phase one, you need to think about phase two. And phase two is where you're thinking about either a home-based program or a institution-based cardiac rehab program. Again, your institution-based cardiac rehab program is straightforward as per the guidelines. Nothing too fancy. I mean, nothing too different from what we already know. But the home-based program, on however, is something which we do quite different. It's primarily a walking program, and we've used this program quite well for not just heart failure patients, but also for a higher risk group of patients, primarily looking at those with pulmonary hypertension as well. I do understand that this may be a challenging group to see, but nevertheless, pulmonary hypertension is also quite common secondary to certain infections, which are quite common. And you may see a few of them, and they are also a group that do benefit a lot from exercise training. This was a review that we did a few years back, which did show that participation in exercise training improves functional capacity and quality of life. If they, and it didn't matter whether they exercised in hospital, it was a hybrid program where they did some of it in the hospital and some of it at home, or whether they did it only at home. They just needed to be exercising in one place to find that there was improvement in functional capacity. This was a program that we had delivered for patients with pulmonary hypertension, for which was delivered over 12 weeks. And as you can see, exercises were progressed every 2 weeks. Patients received a specific exercise manual. It included a combination of aerobic and resistance training, which was offered 3 days a week, 3 to 5 days a week, and patients were all followed up over telephonic calls. Excuse me. And most of the exercises were delivered at a moderate intensity. And patients could actually tolerate it really well. And we did find that quality of life and functional capacity did improve quite a bit. So these are, again, very simple programs, no fancy equipment. All they did was to improve resistance, was either to use water bottles to raise and progress. And telephonic calls every week helped us understand how they were finding the programs. We were able to tailor the repetitions. In some of them, increase the number of sets, and some of them bring it down a bit so that they were quite comfortable and it was not harmful in any way. So now I come to, what does ICCPR have, and what do we as ICCPR do, and what is our role in looking at promoting cardiac rehab? So the International Council of Cardiovascular Prevention and Rehab was created in 2010 to bring together associations that were dedicated to the promotion of cardiovascular disease prevention and cardiac rehab around the world. Some of our goals are to bring together national organizations to work on ongoing consensus with these associations to set standards for prevention and rehab, to promote a lot on cardiovascular prevention and rehab, to support countries to establish and augment their programs, and also to consider and communicate the emerging evidence base for cardiac rehab. Our mission is to advocate, educate, and evaluate these prevention and rehab programs. At the moment, we have 51 member associations who are a part of us, and we also have a good number of friends of ICCPR. And friends are are important members of our community, and they represent countries where there is no formal professional organization for cardiac rehab or for the profession that can be represented in ICCPR. So the cardiac rehab certification the foundation certification program is an education program that helps to build and scale up healthcare professionals in the area of cardiac rehab. It covers all the important core components of cardiac rehab, and this is based on a previous ICCPR consensus statement that was developed. It does cost $125 US But if there are concerns, please do reach out to us and we will see how we can help you. It is completely online and you have an exam that you need to take at the end. These are the modules that are currently there. So as you can see, we cover various aspects of it, from patient assessment, lifestyle risk factor management. We look at exercise training. We look at mental health, tobacco cessation, diet. Also look at medical risk factor management. Some excellent sessions on patient education, counseling, and delivery of cardiac rehab, and also engaging women in cardiac rehab, which is an optional module that can be done. When we looked at how effective this has been, it has reached a good number. This was done in 2021. It We have reached much more people now, and most of our participants are quite highly satisfied with the program and do recommend it to others. And we encourage you to do reach out to us if you have any queries on the CRFC program. In keeping with its mission, ICCPR is also embarked on establishing an international cardiac rehab registry, which is the first of its kind. We have centers from all around the world, and these are centers that are delivering phase 2 cardiac rehab programs. And these centers are part of the registry, and those which have been doing really well also are certified by ICCPR as a certified site, which adds a lot of value to your program. It helps in benchmarking because you can see how other centers, how the rest of the centers are doing and where you stand, and you can help in building up the quality of your program. You can talk about quality initiatives, which are also supported by ICCPR. And again, if your site does really well, your program gets accredited and recognized. We have used certain quality indicators, which are again available on the ICCPR website. But just to tell you what it is, because it's important to know so that you can, if at all you're thinking about setting up your program, you can ensure that it covers at least some of these components. So make sure it's comprehensive. Can you deal with an initial assessment, providing structured programs, supervised or unsupervised? How can you ensure that various other cardiovascular risk factors are also controlled? Can you have a multidisciplinary team? It's very important to have an emergency policy. We sometimes forget that a lot of our patients are high risk patients and they can suffer from a cardiac arrest. So, as a healthcare provider, you need to be trained adequately in the delivery of emergency services like basic life support, cardiopulmonary resuscitation, or at least, and also ensure where you can get that help if something happens. Think about how various members are going, how you're going to assess various risk factors like tobacco use and other risk factors. Look and see how you can measure exercise capacity. You can use any method, and you may just need to look at a conversion to METs. Can you do quality of life evaluations? Can you think about changing their intent, their activity levels? Can you see how much of them have changed in their education about their condition, their medication use, their healthy diet? And of course, also to remember that, can you get at least more than 50% of them to complete your program and not drop out for any reason? So I think these just give you an idea as to what are the quality parts of your program that you need to think about to assess and determine whether your program has met all the required check boxes. So would you like to do more? And as a community, how would you like to be engaged more? Well, ICCPR is starting its 2025 cardiac rehab audit, global audit and update. And we invite sites that are running cardiac rehab programs to participate. And the reason why we want to do this is after COVID, we do not know what has happened to a lot of our cardiac rehab programs. Uh, with COVID, we saw that almost 75% of our programs stopped or were paused during the pandemic. and some of them did close completely, but now they've all shifted to a more hybrid or technology-based cardiac rehab program. So if you run a program or you have a program that is there, do complete this online survey. We hope to run this survey till around July, August of this year, and it's just been launched this month. If you respond to it, you will have the opportunity to do the CRFC program for free. So that's something that but again, remember, it is one entry per site. So it has to be a site that offers phase 2 cardiac rehab program as an out in your center. And you need to be able to offer at least 3 of these components. So initial assessment, structured exercise, and some form of control for cardiovascular risk factors. So if another person has already completed your team, from your team has completed the survey, your survey will not be counted. So please make sure that it is only one survey per site. It is not, we're not looking at the number of individuals completing it, but the number of sites completing it. And if you run only an inpatient rehab program, again, your center is not eligible to participate. Look at what's happening on our social media. You can follow us on X, Instagram, Facebook, and LinkedIn. And we hope to have some data out, and you will see the results of this once we have finished our program. And this is being run by Dr. Gabriela Gysi and Professor Sherry Grace, and acknowledgements to them for this wonderful initiative that they are launching right now. And we are being supported by a lot of our member organizations as well. So to conclude, cardiac rehab is vital, and I think we all agree on that. Starting points are sometimes with only inpatient rehab, and you can expand it to home-based rehab after that. It can be delivered very effectively in a simple and inexpensive manner. You do not need all the bells and whistles. Upskilling is important, and it is also important to translate evidence that is there into practice. ICCPR has opportunities to network, collaborate, and build cardiac rehab in your country. If you have any questions on behalf of ICCPR, please do reach out to us at this email address, and we'll be happy to help you out and connect you to others as well. Thank you for your attention. And I'll be happy to take any questions you have now.
Okay, thank you so much. Thank you so much, Dr. Babu. That was quite exciting and detailed. Please,
Thank
can we
you.
appreciate him? Can we appreciate him with G of our choice? This is an international, this has an international term, and I'm so glad that such an international celebration in trying to tidy cardiac rehabilitation all around the world. Because I know that physiotherapists in different centers in Nigeria are involved in cardiac
Olive,
rehabilitation.
could I
But
just interrupt you a bit? It's not very clear for some reason. I'm hearing it quite muffled.
Okay. Okay,
Yep.
I'm coming.
Increase my
Yep.
volume.
Oh yeah, that's much better. Yeah.
Okay, so I was just expressing my
Oh,
sincere gratitude to you for coming on board to give such a presentation, and it gladdened my heart to also hear of the level at which there's a global structuring of cardiac rehab in such a way that it could be better structured and better delivered. So I'm happy to hear that. So please, can we appreciate him more? For all of us that are here, it's not easy to get Dr. Babu to be awake till this time of the night. We're not taking it for granted, sir. So
thank
thank you
you.
so
Thanks for
much.
the opportunity.
Thank you. Well done, sir.
Thank you. Thank you
So
so much.
at this point, we will want to entertain questions, comments, contributions And if there's any suggestion too, it will be welcome. And in our tradition, we usually continue this discussion on the platform. And we have already added Dr. Babu to the platform. So even if we don't exhaust everything here, we'll continue chatting with him and seeing how we can benefit from his position, even as the vice chairman of the ICCPR, which is a very good opportunity that we have. So if you have questions, you can raise your hand or you can put it on the chat box. We'll attend to you. I can see my HOD, my head of department, has already raised her hand. So Ma, please, can you unmute yourself and say something to us? Thank you so much.
Thank you. Thank you very much, Ezine. Thank you, Dr. Babu. Thank you, colleagues. Good evening, everyone. Thank you for coming on board to have this discussion with us.
Thank
We are
you.
really very grateful, and I'm happy a lot is already happening. And I know that with this, we all have to plan how to get our centers going in the right direction, because there are patients every day and something has to be done for them, and that something has to be done right. So I'm happy we're having this discussion. I just want to appreciate you to tell you that I know many of our colleagues are here, and our center, is a cardiothoracic center of excellence. So we have a lot of work to do to get going and in the right direction with the rest of the world. We know we have a lot of limitations, but I'm also happy that you're speaking for resource limited centers, that everything doesn't have to be high tech. Everything doesn't have to be high tech. Everything doesn't have to be expensive. There are other things that we can do that are not really, really high tech. So we can't just say, because we don't have high tech this and high tech that, we don't have anything to do. It's clear that we have a lot that we should do and we can do even in resource limited settings like ours. So thank you very much. I just want to appreciate that. I'm glad. Thank you, sir.
Thank you. Thank you so much. And I think, never underestimate what you have. The work that comes out of the simple things is probably what makes the biggest impact.
Thank you.
Thank you, Ma. Thank you for your contribution.
Thank you.
Thank you. So, okay, we have, I can see that Dennis has raised his hand. Please, can you unmute yourself and make your contribution, please?
Thank you very much.
Dennis, can you hear me?
Yes, I'm hearing you. Can you hear me? Can you hear me?
It's very faint, but I think go ahead. We'll see if we can hear you.
Okay, thank you very much, Dr. Babu, for the nice presentations. I have a little concern. I don't know how are you doing to get these patients. Earlier patient when they're in the ward, the referral. Which type of referral are you using? Blanket or open, or how do you make it so you receive this patient? Is this patient with ischemic heart failure patient, coronary, acute coronary? How did you get this patient? Because it has been difficult for the physician cardiologist to understand this. So I don't know which way are you using that.
So I think you raise a very
That's a
important
very
question,
important
Dennis.
question.
Yeah. And
Yes.
I think before we get to the automatic referrals, I think I probably should go back a step before that to tell you what is involved before you even get to that stage of referrals. What I have done in the past was to work quite closely with the cardiologist to choose a very specific group of patients initially, saying that these are the groups we want to work on, and they may be low risk patients. So what I would recommend initially is to take MI patients who, fairly uncomplicated MIs who have done quite well. Take them and start asking them if they can be a part of your program. Have a conversation with your cardiologist. You don't need to do large numbers initially, just do a few, but it is important for them to know that you are in a position to handle those patients and that you can deliver and demonstrate an outcome. Once you start seeing the outcomes, it's a lot easier to then pitch for saying, can we now see all your MI patients? And if there is a concern, you just need to tell us. Otherwise, if most of them are all right, which is the case very often, uh, we will just go ahead and see all of them. So it does take time. It's not something that we can build immediately. Uh, we use a blanket referral here in our center, but uh, I will also tell you that it's taken us years to reach where we are now. And it's taken a lot of work to demonstrate that it does work that way. I hope that was helpful for you.
Yes, sir.
Okay, thank you, Dennis. Thank you, Dr. Babu. It was quite it's a very serious question that Dr. Dennis has raised here, because that issue of referral is quite challenging. So, Dr. Babu, what do you mean by blanket referral? At least I understand automatic. For us in University of Nigerian Teaching Hospital, there are some automatic referrals that we get because
Yep.
we work in ICU. So some patients that get into ICU automatically becomes our patient, and we follow them to the ward, and we continue with them, continue the rehab. But sometimes, if these patients don't come through ICU, we tend to lose them. So it boils down to the fact that we need to have a closer relationship with the cardiologist and take it from there. But can you explain what you mean by blanket
Mm.
referral, please?
Yep. So I think it's very similar to what you just said. So our referrals are either complete referrals based on the area that they are in. So similar to an ICU, for example, all the patients in the ICUs are available to us to see, and we can choose. We also do the same thing with all patients admitted to the Department of Cardiology, the Department of Cardiac Surgery. All the patients are referred. We don't exactly wait for a referral per se, unless the cardiologist then feels, this is a patient I really want you to see sometimes, and he doesn't want us to skip that patient thinking that, well, it's not a high priority for us. In those cases, there would be a specific mention done. So I think it's probably very similar to what you said between blanket and automatic. I think we just probably use the term slightly different. But what I meant by blanket was that everyone in that unit or in that department would be considered eligible for physiotherapy at the physiotherapist's discretion.
Okay, thank you. We have some participants that logged onto our YouTube. I don't know if they have a
Okay.
question, but as we're waiting for them, I can see that PT Adobe raised her hand. Please, can you unmute yourself and make your contribution or question, please? Thank you. Ada Obi, are you there? Can you make your question? Can you ask your question? Okay, while we're waiting for her, we have a question online, but I don't really get the question. Maybe I will read it out. Maybe Dr. Babu, you can understand what the person is asking. The person said, "Good evening, sir. For a patient with HFrEF, he didn't write this in full. What is the safe EF range to start home-based
All right.
cardiac rehab?"
Yep. So the question is talking about a patient with heart failure and reduced ejection fraction. And
Okay.
the part and Ms. Shiba would like to know whether what is the safe ejection fraction range that is considered safe to start a home-based cardiac rehab program. And so heart failure with reduced ejection fraction is a type of heart failure where the ejection fractions are usually lesser than 40%. In terms of safety, well, we do not have ejection fraction based cutoffs as far as I am aware of. Um, we use a lot based on symptomatology. So, because we do know that a lot of the uh, safety factors are driven by a lot by also symptomatology and not alone, just only by ejection fraction alone. There are many other things we need to consider. Uh, to be honest, we have worked with patients with extremely low ejection fractions and have had absolutely nothing wrong with them. Uh, what I would recommend is always start with the most stable patients initially. So, you know, 30 to 40 first, make sure that they are all right. You can handle them, because as the ejection fractions come down, it's important to be able to recognize early signs of decompensation, which require you to tailor the program, sometimes even require you to advise your patient to seek medical help. So it is important to take those steps fairly slowly, and take levels up to which you are comfortable with. Um, I unfortunately am not aware of a specific number that is associated with the ejection fraction, but I would still say go slow. I'm not sure if I completely answered your question there, but uh, I hope it was helpful. So there's another question by Edward Elijah. Is there any specific published guideline you would recommend for vital signs to consider a patient for a start? Uh, Most of the guidelines just say that patients need to be medically stable. Um Medically stable is defined as having normal hemodynamics or acceptable hemodynamics. So a lot is, especially in cardiac rehab, a lot is around hemodynamics and rhythm. Um, I again am not aware of a guideline that talks specifically for vital signs. Most of your cardiac rehab guidelines will just talk about eligibility in terms of uh, medical stability or hemodynamic stability, and most of them come to us after a referral from the medical professional who has determined that they are stable. So uh, I am not very sure if there is a specific guideline that is there. But my suggestion would be that, make sure that your evaluation is thorough, and if in doubt, discuss with the clinician, because it's important that the clinician realizes that you are able to voice out concerns, and that builds the rapport, that builds the team, which again helps over a period of years to just say, yeah, well, just handle the patient any way you want. But it's important to have those discussions with the cardiologist or with your cardiac surgeons. Right. Um,
So good evening, myself Shiva from Tamil Nadu.
yes. Yes, Shiba.
Okay,
Go ahead.
thank you very much. Ada, Bujo wants to ask questions. I can see your hand is still up.
Ma'am, can I proceed?
Shiba,
Yes,
just
sir.
wait 1 minute. I think
Yeah,
Miss
sure, sure.
Adobe has
Yes,
a.
you can proceed. Sorry about that. You can. Go on.
Okay. So my question is, you've suggested a course in ICCPR, right, sir?
Yeah.
CRF course. Yeah. So is it mandatory to get the support of ICCPR to support our outpatient clinic wise? Because we
No,
have
not
already
at all.
completed MPD cardiopulmonary sciences, so we are almost aware about the cardiac rehab and all. So is it mandatory for us to attend this course again, once again, to get the support of ICCPR?
No, this is not a mandatory course. This is just a course that we run to build capacity. to train more individuals in cardiac rehab. And from my understanding, a lot of our cardiac rehab curriculum focuses a lot on the exercise and physical activity part. The advantage with the CRFC modules are that each module is taken by an expert in that area. So when we talk about patient education, for example, Dr. Gabriela Gysi, who's the chair of ICCPR, is an expert in patient education, and it is her presentation that you hear under the patient education module. It is an add-on. It is something that is in addition to what you have done. ICCPR makes no claim or requirement for something to be mandatory. It is completely voluntary for you to do a program. This is like any other training program that you would do. It is one of the training programs that is available for you in the space of cardiac rehab. Does that
Okay.
answer your question?
Yes, sir. Yes, sir. Thank you. So, even if we don't complete the program, we still have a chance to get help from ICCPR to develop our cardiac rehab OP outpatient based center.
Yeah, so if you are doing that, I think there are a lot of instructions
Okay.
on the website, but one of the requirements if you want to participate in the cardiac rehab registry is that there has to be one CRFC trained person at your site. That is one of the requirements for us as ICCPR to have you on as a site for the cardiac rehab registry. Uh, so if you can look at the criteria that's there, I think it may give you that little bit of clarity, but I'm happy to answer any other questions related to that as well. We can even do it. You can contact me. You have my contact details. You can reach out to me also, and I can help you with that.
Sure, sir. Thank you. Thank you.
Right. So Dennis has written in a comment, I think we can use ejection fraction for categorizing patients with heart failure to high, moderate, and low risk. Is it right? Yes, in the AACVPR risk stratification that is used at the time of discharge, ejection fraction is used as part of the risk stratification, and you are right on that. Thank you, Dennis. Right. Ms. Emeka Ozioko. I'm sorry for mispronouncing names. Um, sorry, I can't see Olive, so I will just look through. Emeka, would you like to unmute and ask your question? Okay. Yeah. Emeka, you can go ahead and ask your question. Unmute and ask your question, please. Emeka Ozioko. Yeah, please go ahead and unmute yourself and ask your question. Olive, over to you. Okay. I hope the sessions were helpful, and for those of you working in Nigeria, if there are concerns that you have, and if there's anything you need in terms of building up, setting up programs, or building on what you have, um, either in terms of raising the quality of the programs that you have, establishing it. I mean, for all participants on the call, I wouldn't say it's only for those who are in Nigeria, but anyone who's on, if there's help that you would require or you need some guidance in how you can go about setting up and establishing a center, please do reach out to us in ICCPR, and we'll be happy to see what we can do to help you through that process of setting up a rehab program in your site as well. All right. I think our host has gone offline, so I'll just need to wait for her to come back on. So maybe if I could just ask for those of you who are from Nigeria, uh, how many of, I mean, are there many of you at the moment working in with cardiac patients? You can either just type in yes or, you know. All right, wonderful.
Hello,
Yeah, hi,
can you
hi,
hear
Olu.
me?
She's back.
Yes,
Welcome back.
Sorry, the network threw me out and I
that's
couldn't join
perfectly
back again.
that's
So
perfectly
I'm
all
so
right.
sorry
It
about
happens.
that. And
No problem. No problem.
so I believe we've attended to all the questions.
Yeah.
Okay, Dr. Babu, I want to thank you. I believe we've attended to all the questions, and please, I will plead with you to still stay with us on the group,
Yeah.
so that
Sure.
probably we can really structure cardiac rehab in Nigeria through your guidance and guidance of other physiotherapies that are already in the team.
Yeah.
So I want to use this opportunity to appreciate you and also to thank Professor Jubril Mohammed, because he's actually the one that linked us together. I want to appreciate him. I told him that I'm standing on his shoulder. So thank you, Professor Jubril. Thank you for helping us to get Dr. Babu. Thank you, everyone, for participating. Thank you, our colleagues in India that also joined this presentation. Thank my HOD who has stayed on till the end of this presentation. Thank you to all those that asked questions, those that made contributions. I know that we had this discussion at a time that is not very convenient in Nigeria, but I'm so glad that a lot of us will come on board. And we have really, had a very wonderful stay with Dr. Babu. I guess so. So thank
I'm
you.
glad.
On this note, I want to bring this meeting to a close so that Dr. Babu can go and have his night rest. He's almost getting it 11 p.m. and
Yeah.
every other person. So thank you. Thank you so
Thank-
much. So good night, everyone. As you are leaving, just drop your own emoji in appreciation to everyone that has been here, especially to our speaker. Thank you so much, and goodbye from me. Goodbye from me. Goodbye from Nigeria.
Thank you so
Thank
much.
you. See more of
Thank you.
you.
Bye
Please,
bye.
your emoji, Dr. Babu, we are saying thank you. And we're saying good
Thank
night.
you. Thank you and good evening, everyone. Thank you. Bye-bye.
You.
Good night. Bye. Thank you, Dr. Babu. Thank you,
Bye.
Ezini.
Thank
Good
you
night,
so much, and
everyone.
thank
Bye,
you.
everybody.
Good night. Bye-bye.
Thank you, man.